today, let's talk about the regulation of the heart. So some of the heart contractility, not only are we going to see that calcium is really important, is the sympathetic and parasympathetic system really important, there's also the general inherent capabilities of the heart to contract really through the normal myogenic mechanism. So remember, when muscle is stretched, it responds by contracting. So one of the things that can determine stroke volume is the preload. And that's also going to involve another item called the afterload. So we'll go over that in just a second. So you're going to see quite a few of these curves. These are stroke volume curves, and they tell you the amount of stretch of the heart. So that's your preload, the stretch, whereas the stroke volume is what is ejected from the ventricles. So thinking about the regulation of the heart makes more sense when you think about what happens when you don't have nervous regulation. So in some studies, they'll use greyhounds a lot of the time. Greyhound racing dogs are generally about 2-year racing career, so they have been utilized for some physiology studies. In this study, they denervated the hearts of racing greyhounds. So that means they separated any of the sympathetic and parasympathetic nerves that would be associated with the heart. And what they found was the heart running on its own without any sympathetic or parasympathetic input was that their racing speed only decreased about 5%. So that tells you that even though there is regulation through those systems, it's not all of the story. There are circulating catecholamines like norepinephrine, epinephrine, dopamine that turns into those things that are released by the adrenal glands, but the heart does have its own mechanism for regulation. So we call that intrinsic regulation. So two of the things you have to be really familiar with to understand this is preload and afterload. So here's a good little angry looking heart, and it's showing you preload and afterload. So preload, so it's kind of like preloading your dishwasher or something of that nature. It's how much blood is stretching the ventricles. So the volume entering and then stretching the ventricles, that's the preload. How much is the stretch? And that will determine stroke volume to some degree in relation to the afterload. So the A in afterload, I want you to think about as also the A in aorta, because the afterload is the resistance out in the system, so out in the aorta, for example. How much pressure is there that would be opposing the blood from entering? So when there's really high pressure in the system, like in high blood pressure, there would be a high pressure pushing back to the heart, preventing the full ejection of the stroke volume. So preload, again, and afterload, those are two things that are going to determine the stroke volume. So remember, just like a rubber band, if this is a rubber band and I stretch it really strongly, that's like having a high preload. That's going to be a really strong snap. However, if I just weakly stretch the rubber band, like put a little bit of preload in there, the snap's not going to be that hard. So preload is the stretch, and then the pressure that has to be overcome by the heart. So how hard the heart has to contract to eject that stroke volume. That's our afterload. So afterload is resistance in the system, like in the aorta, and preload is the stretch of the ventricles initially when it's filling. This collectively is referred to as the Frank-Starling Law of the heart. There aren't very many laws in medicine and physiology, so if you see one, it's always a good idea to be familiar with it because it's a law. So what the Frank-Starling Law of the heart states is really just the greater the stretch, the greater the stroke volume. Greater the preload, the greater the stretch, the better the strength of contraction, and then the more contractile the force is. So Frank-Starling Law of the heart: increased blood volume, increased stretch. The more it stretches, again, just like a rubber band, the greater the force to pump the blood out and then overcome that natural afterload pressure. And when we look at a myofibril, our actin and myosin little strands, the greater the stretch, the better actin and myosin are oriented towards one another, our little thick and thin bands, so that we can have these filaments slide together. So the greater the stretch, the better primed the separate strands are to contract. What you're looking at here, ventricular function curve. So you see that same curve again, like our nice little stroke volume curve. On the y-axis, we have the stroke volume or amount of blood that is leaving. And on the bottom x-axis, we have pressure. So we have left atrial pressure, right atrial pressure. So this is showing you the more pressure there is in the atria, the more can be ejected from the ventricles. Greater atrial pressure, greater ventricular volume output. Remember that it's the atria's job to add that extra blood. So if the atria are able to contract really strongly, there'll be more blood in the ventricles, it will stretch better, and then generate a stronger contraction strength and larger stroke volume. Okay, so that's one of the intrinsic regulators, preload and afterload. And then we have the overlay of the autonomic nervous system. We have information coming from sympathetic and the parasympathetic system. We'll see in the next couple of slides. Predominantly, you'll see the parasympathetic. Remember, that's our rest and digest. So our PNS, rest and digest. That's also called the craniosacral system because there's cranial nerves and then nerves coming from the sacral region. Mainly, the parasympathetic rest and digest will overlay the system to mainly control the resting heart rate. So you'll see that most of the connectivity will be to the SA and then the AV node. So it can reset the resting heart rate. Whereas the sympathetic output, so T1 to T4, we'll see preganglionic come out to the sympathetic chain ganglia, make a nice little stop, the sympathetic cardiac nerve, and then will become a very complicated plexus. So in this picture, it looks like there's only a couple of nerves. But when we have sympathetic nerves coming out to the heart and squirting out norepinephrine, not only will that affect the nodes, so the SA and AV nodes, to increase the heart rate, because now we have to exercise or be stressed, but it will also go and innervate all of the myocardium as well. So it's not just going to increase the heart rate, it also increases the strength of contraction. All right. So as I mentioned, both sympathetic and parasympathetic are going to be involved. Parasympathetic is going to predominantly control the resting heart rate in normal basal conditions, where the sympathetic will only take over during cases of exercise and stress. The sympathetic nervous system increases what we call automaticity. So something's automatic. Automaticity in humans would be like you just doing something without thinking about it, like going for a walk and then looking around thinking, I don't remember walking here, or showing up at school in the parking lot and you don't remember everything about your drive. So that's you being in automatic mode. But automaticity of the heart, that means that the cardiac cells can spontaneously generate an action potential. So sympathetic nerves enhance spontaneous generation of action potentials, meaning the heart can beat really strongly, really quickly, whereas parasympathetic decreases that. So there's less likelihood of generating its own independent action potential. Both of these, if they are blocked, you return to what's called the intrinsic heart rate, which is 100 beats per minute, which means there's no nerves to increase it, no nerves to decrease it, so you just get stuck at 100. If that's the case, that is when you would see people implanted with a pacemaker to control the internal conducting system of the heart. Okay, when we look at these systems, the parasympathetic and sympathetic, we have to remember not only where they come out, but also what they're conveying. Sympathetic is releasing norepinephrine from the postganglionic neuron, where the parasympathetic is releasing acetylcholine. The receptors involved, so mainly on the parasympathetic connections to the AV and SA nodes, you'll see muscarinic type 2 receptors. Remember your rule for odd and even. This is an even receptor, which means that it's an inhibitory receptor. It decreases things. So when we have acetylcholine binding to the muscarinic type 2, that's going to decrease the heart rate, that's kind of funny, and decrease the force of contraction. Whereas in the sympathetic nervous system, we have norepinephrine binding to beta-1 receptors. 1 is odd, which means it's an excitatory receptor. So when norepinephrine binds to beta-1, you'll have an increase in heart rate and force of contraction. These beta-1s are all over the entire myocardium, all parts of the heart. Beta-1s everywhere, the whole thing. Where the muscarinic type 2 are really just going to be associated with the nodes, the SA and AV nodes. Okay, the parasympathetic, medulla oblongata, they're going to come down near the carotid, which is why when people get carotidectomies, they actually have to clamp this to get to the carotid, so there's going to be difficulty even using the glossopharyngeal for a while because your nerves don't like things messing with them. And they're going to come all the way down. They're going to synapse with their postganglionic cells. This is parasympathetic. Remember, the ganglia are within the target tissue. So they're either going to be on the epicardium, so the surrounding fibrous layers, or within the myocardium itself. Again, most of these are going to be right by the SA and AV nodes, squirting out acetylcholine, binding to muscarinic receptors, and lowering the heart rate and force of contraction. You should know by now that the vagus is involved with almost all control of the hollow organs, of which the heart is one. The right vagus, remember, coming from the medulla region, that is going to go to the SA node to slow SA firing, where the left vagus is mainly going to go to the AV node and inhibit the AV from conducting its own. There is a little bit of overlap. You can see that here. The left also depresses the SA, and the right also branches over to help with AV. And that's important because if one of these is damaged for any reason, we still have redundancy on each side. Okay. Because we have acetylcholine coming out, binding to muscarinic type 2 receptors, and then setting the resting heart rate, it's important that if this is a receptor, this is our muscarinic type 2, that acetylcholine not just hang out here. We want it to bind, we want it to stimulate that receptor, and then it pops off. It does that. So that means the nodes have to be rich in the big enzyme that breaks down acetylcholine, which is called acetylcholine esterase. Easy name, right? Acetylcholine esterase. So what that does is break down acetylcholine into component parts, acetic acid and choline. So that means that when acetylcholine is released, it goes and activates its receptor, it can regulate potassium channels, and then it's broken down right away. Because if there's too much acetylcholine here, you'll start to have depression of the cardiac system. So we need to make sure that it is removed. All right, so remember that we've got odd and even receptor numbers. Acetylcholine binds to nicotinic receptors and muscarinic. The nicotinic are physically on the postganglionic neuron, whereas the muscarinic receptors are the ones on the tissue. So here, there's a great picture. It's one of my pharmacology pictures. It's beautiful. Here's the vagus nerve releasing acetylcholine. Acetylcholine is binding to the muscarinic type 2. This is a G-coupled protein receptor. It's using adenylate cyclase as its second messenger that decreases cyclic AMP and lowers the automaticity of the heart. One of the ways to block this system, an anticholinergic drug, is atropine. Atropine, if you've ever had your eyes dilated, that's what atropine is. It's a general acetylcholine blocking drug. So this picture is also showing you that we can block acetylcholine activity by giving atropine and preventing binding. So that would be important for somebody who had organophosphate poisoning, ate a mushroom that they found in a field, or somebody that is taking cholinergic medications, like for GI disorders or for blood pressure. You can overdose on them. So the main parasympathetic receptor is our muscarinic type 2, remember, mainly by the nodes, SA, AV nodes. Decrease the amount of contraction, decrease the heart rate, decrease automaticity. Sympathetic, we learn T1 to T4. Don't be surprised if you take a test for me and I ask you that, because you'll have to know that for your lifetime. Congrats. So here's our preganglionic neuron coming off of the cord, synapsing in the sympathetic chain ganglia. Remember, both the sympathetic and parasympathetic release acetylcholine from the preganglionic. In this case, the postganglionic binds to nicotinic receptors, which are always excitatory, and then the sympathetic system releases from the postganglionic neuron norepinephrine. As we mentioned a couple slides earlier, it will go out and bind to places on the SA and AV node to increase the heart rate, but it also will form a complicated plexus to go out to the entire myocardium to increase the force of contraction all over the heart. All right, so this is showing you where the nerves come from. This is a little bit more of an accurate picture where you see all of the sympathetic nerves coming out to innervate the entire surface of the myocardium. So the entire mediastinum is really covered with these complicated plexi of sympathetic nerves squirting out norepinephrine and binding to its receptors, which predominantly are the beta-1 receptors on the myocardium. So that's what you see here. We've got beta-1 receptors. So here's norepinephrine being released from the postganglionic neuron. The norepinephrine can bind to the beta-1 receptor. There's another G-coupled protein receptor using adenylate cyclase. In this case, we have an increase of cyclic AMP and then contraction. We also have beta-2 receptors on the surface of the myocardium, just to make life complicated. But the beta-2 receptors down here, those can still be activated by norepinephrine and epinephrine. Just remember that beta-2, it's even, so that's a more inhibitory type of receptor. Okay. So the norepinephrine, about 70% is taken back up into the nerve because your body hates to make things from scratch. The other 30% is going to go circulate in the bloodstream to keep stimulating the rest of the organs to stay in sympathetic. And then norepinephrine is released very slowly, uses cyclic AMP, adenylate cyclase, and eventually will be broken down by phosphodiesterase so that everything can reconfigure and norepinephrine can bind again. Ta-da! All right, so here are your receptors. Oh, look how complicated this is. I love it. So we've got alpha receptors that epinephrine can bind to. Remember, alpha and beta are what norepinephrine bind to. Predominantly, you're going to see our beta-1 on the myocardium. There's also some beta-2, as I mentioned. There is a presynaptic alpha-2 receptor. See this 2? Remember, that means that it is inhibitory. When there's too much norepinephrine here out in the cleft, it will bind to this alpha-2 receptor, which will shut off the production of more norepinephrine and the release of more epinephrine. That's your body's signal that there's enough norepi out there and not to send any more. All right, again, we've got our beta 1, beta 2. Main one is going to be our beta 1. Here again, G-coupled protein, adenylate cyclase, increase in cyclic AMP. We're going to have then calcium entry, bind to their ryanodine receptors on the sarcoplasmic reticulum, liberate the stored calcium, and increase the force of contraction even more. Our calcium-induced calcium release. So norepinephrine is important, and our calcium, which drives the force and strength of contraction. Woo, and that is it for this. So just going through this question really quickly, stimulation of the CNX leads to which result? CNX, which cranial nerve is that? Cranial nerve 10. Cranial nerve 10 is the vagus. The vagus is part of the parasympathetic nervous system, the rest and digest. So if you stimulate the vagus, what's it going to do to the heart? It's going to rest and digest. So does that mean it increases? No. Does that mean it decreases? Maybe. Does it have anything to do with calcium release? No. So that's wrong. No effect. Well, no, that's not true either. So we know this cannot be true. That's sympathetic. The only correct answer is this decrease in heart rate, parasympathetic, rest and digest. That is the correct answer. All right. Good luck, everybody. Stay safe out there.